Hi everybody, I am Dr. Raina Chawla, your faculty for Obs and Gynae, and in this important topic we will be discussing intrapartum fetal monitoring, that is monitoring of the fetus during labor. We've already discussed antepartum monitoring, that is monitoring during pregnancy, but a very important part is also monitoring of the fetus intrapartum, because labor is a stress and we need to see how the fetus reacts to that stress. So it is basically response of the fetus to uterine contractions. The uterine contractions are a stress to the fetus. During contractions, there is reduced blood supply to the uterus and hence to the fetus, and a good healthy fetus who is not hypoxic will respond normally. We will not show any signs of distress, but a fetus who is already acidotic, who is already hypoxic, will show signs of distress in response to fetal contractions. So this is what we need to see, how the fetus responds to stress and whether the fetus is hypoxic, acidotic and requires urgent delivery either through a cesarean or through an instrumental delivery. Now, what are the aims of intrapartum fetal surveillance? The first is to identify or basically identification of decreased fetal oxygenation, timely and active effective intervention, that is delivering the fetus timely either by a cesarean section, or if she's fully dilated we can expedite delivery by using an instrument, and prevention of brain injury. So these are the important aims and why we need to do it. Now, what are the methods of intrapartum fetal surveillance? We can have intermittent auscultation, and this is what is usually done in low risk women. So in low risk women, intermittent auscultation, that means using the stethoscope or the fetoscope, we auscultate the fetal heart rate, and we will discuss a bit more about this. Second is cardiotocograph or CTG. We've already discussed an NST. It's basically the same machine, but it's called a cardiotocograph because it has two components. It has a component of cardio, that is the fetal heart rate, and toco, that is the uterine pressure, and we see the response of the fetal heart rate with relation to uterine contractions. Then we have the less commonly used ones, especially in our country we don't do, but in the UK it's very commonly done, fetal scalp blood for pH. This will tell us in reality whether the fetus is actually acidotic or not. Also, fetal scalp blood for lactate can be done, fetal ECG and fetal pulse oximetry. These are more or less more of academic things. They're not really actually done in most practical scenarios. However, fetal scalp for pH and lactate is done in some countries but not in our country. Now, intermittent auscultation is very important. This is what is recommended by in most low risk women. We don't have to do anything else but intermittently auscultate. Now, the things you need to know is, when do we auscultate? We auscultate the fetal heart rate. So you can see here, a fetal handheld Doppler is being used. We can also use a stethoscope or a fetoscope. Okay, when is it done? It is done right after the peak of a contraction. Okay, and why is it done at this time? Because if the fetal heart or the fetus is distressed right after a contraction, the fetal heart will drop. What we call in a CTG a late deceleration. So you can pick up a late deceleration by auscultating right after the peak of a uterine contraction. Okay. The other thing is, how often does it need to be done? It is done every 15 to 30 minutes in the first stage of labor. What is the first stage of labor? The first stage of labor is from onset of true labor pains till full dilatation of the cervix. And in the second stage of labor, what is second stage? From full dilatation of the cervix till delivery of the baby. It is done every 5 minutes. So every 15 to 30 minutes in the first stage we auscultate for the fetal heart rate, and in the second stage of labor, that means once she is fully dilated, we do this every 5 minutes. These are the two important things you need to know. when is it done, and how is it done. Also remember, it is done usually in low risk women who are in labor. The second important type of monitoring is electronic fetal monitoring. Now, electronic fetal monitoring could be of two types. This is an external type of monitoring, what is called the CTG or cardiotocogram. You can see this is the cardio probe and this is the toco probe, which is measuring the uterine pressure. Another type of electronic fetal monitoring, which is less commonly used, is the internal monitoring. Okay, it is less commonly used because it is not very comfortable for the patient, and secondly, it can only be used once the cervix has dilated to at least 3 centimeters and the membranes have ruptured. So you can see the probe has been attached to the fetal scalp. This is measuring the fetal heart rate, and the second probe is measuring the uterine contractions. So this is internal electronic fetal heart rate monitoring. It is not commonly used. But what is very commonly used and what most of you would have seen in your labor room being used is the external CTG, external monitoring, or the cardiotocogram. It is different from an NST because NST is done in the antepartum period, and in NST we're not measuring the contractions. We're just seeing the fetal heart rate in response to fetal movement, but the machine is the same. Okay, the same machine is used. In antepartum it's called an NST, intrapartum it's called a CTG or a cardiotocogram. Now this is an image of a cardiotocogram. Let's look at it a bit more carefully. You can see there's one graph here and one graph here. This graph on top is measuring the fetal heart rate, and this graph below is measuring the uterine contractions or the toco. Okay, so toco means pressure, so uterine pressure. So you can see here, this is the fetal heart rate, this graph here, and this graph is showing the uterine contractions. Okay, so the CTG has several components. In the fetal heart rate, we have several components, same as the NST. What are those components? You have a baseline fetal heart rate. Okay, and the normal baseline is 110 to 160 beats per minute. Okay, then we have a beat to beat variability. Now, normal beat to beat variability is 5 to 25 beats per minute. This basically means, as I've explained in the antepartum fetal monitoring part in the NST, that the fetal heart rate is not static. It is not a straight line. You can see how wavy it is. Okay, this waviness is called beat to beat variability. The third thing we look for are accelerations. Okay, and accelerations, if seen on a CTG, are always a good thing. Okay, they are reassuring that the baby is fine. Can you see this here? This is an acceleration. It is a rise in the fetal heart rate above the baseline by at least 15 beats per minute, lasting for at least 15 seconds. And the fourth thing and the most important thing in a CTG are looking for decelerations, because these are not a nice thing to have. Okay, some are okay, but some are bad, and this is what tells us that the fetus is distressed. What is a deceleration? It is the opposite of an acceleration. So if the fetal heart was going like this, okay, this is called a deceleration, a drop in the fetal heart rate by 15 beats per minute or more, lasting for at least 15 seconds. And we see how the dip is in relation to the uterine contraction. Is it related to the uterine contraction? If it is related to the uterine contraction, how is it related? And that tells us the type of deceleration and our interpretation of that type of deceleration. Now coming to the first component, that is baseline fetal heart rate. Remember, I had said 110 to 160 beats per minute is normal. Anything more than 160 is called as tachycardia. Anything less than 110 beats per minute is called as bradycardia. So you should know some important reasons of fetal tachycardia and some important reasons of fetal bradycardia. So what are the important reasons of fetal tachycardia? Foremost is fetal distress. A distressed fetus will present either as fetal tachycardia or fetal bradycardia. Another reason for fetal tachycardia could be maternal tachycardia. If the mother's pulse is high, the fetus's pulse also will be, or heart rate will be high. Okay, so the mother can have fever. So maternal fever or maternal sepsis could lead to fetal tachycardia. Okay, chorioamnionitis, that is infection of the placenta and membranes, can lead to fetal tachycardia. And also remember, fetal arrhythmias or certain drugs which the mother is taking could also lead to fetal tachycardia. Now, what are the causes of fetal bradycardia? Fetal heart less than 110 beats per minute. Remember, the most important cause is an acute hypoxic or distressed fetus. If the cord gets compressed, okay, for example, if the cord gets prolapsed out, okay, comes out of the uterus, okay, that can lead to fetal bradycardia. Okay, third, if the mother has sudden hypotension, so maternal hypotension, which could happen, say, because of excessive blood loss. If she has abruption or placenta previa, more so in abruption, there'll be loss of blood, and that can lead to fetal bradycardia. So these are some reasons of fetal bradycardia, and again, sometimes arrhythmias in the fetus can cause fetal bradycardia. So remember some common causes of tachycardia and causes of bradycardia. Remember, fetal distress can cause both fetal tachycardia and fetal bradycardia. Now remember, fetal variability, beat to beat variability is, as I said, the fetal heart is a continuous wavy line. It's not like an adult pulse of 72 throughout. If I put my heart rate on a graph, it will come like this. Okay, the fetal heart is changing every second. That is called as beat to beat variability. So this waviness you see is normal. It should be there, and the waviness should be between 5 to 25 beats per minute. It should not be very less. If it's very less, it will appear like a straight line, like how this is. So this is reduced variability, and increased variability would appear something like this. So both extremes are not good. Okay, variability is a sign of an intact autonomic nervous system. Okay, and good variability is anything between 5 to 25 beats per minute. The third component is accelerations. Okay, accelerations are similar to what we talked about in an NST, a rise of the fetal heart rate, an increase of 15 beats per minute or more lasting for 15 seconds or more is an acceleration, and accelerations are very, very reassuring. Okay, you know that the fetus is doing okay. What is a deceleration? Now, the most important part of a CTG is the deceleration. Okay, now deceleration, as I said, is a drop in the fetal heart. You can see these are decelerations of 15 beats per minute or more lasting for more than 15 seconds, and these are always seen in how they are in relation to the uterine contractions, because that helps us tell us what is the type of deceleration and what could be the possible cause. So when we talk about decelerations, there are several types. One is early deceleration, one is late deceleration, one is variable deceleration, then there's something called a prolonged deceleration, and also we will talk about something called a sinusoidal pattern also along with this. Okay, now let's start with the early deceleration. Okay, so an early deceleration, remember, this is the fetal heart rate. Okay, and see these are the uterine contractions. Okay, so if you find that, if you see a pattern or if your image comes in the exam showing something like this, okay, these are early decelerations. Can you see how symmetrical they are with respect to the uterine contraction? That means the nadir. What does nadir mean? This is called a nadir. Your books would say nadir. What does nadir mean? Nadir means the peak or the trough of the deceleration corresponds to the peak of the contraction. Can you see how nicely it's corresponding? What a symmetrical image this is. This is early deceleration. Where is early deceleration seen? The second most important point you should know is it is seen in head compression. So when the fetal head is getting compressed, you will see an early deceleration. Now, when will you see the head getting compressed? Think. you will see the head getting compressed in which stage of labor? In the first stage or in the second stage? You'll see it in the second stage of labor. Why? Because this is where, when the head is descending down maximally, if the head is descending down, the head is compressing against the perineal floor, and that is leading to head compression, and that is leading to early deceleration. So they are not very sinister. Okay, so if you see early decelerations, especially in the second stage of labor, there is not much reason for concern, because these are expected. You're expected to see early decelerations in the second stage of labor because of head compression. So this is not a sign of fetal distress. You are more or less reassured, especially if in the second stage, that these are all right. The second type of deceleration, and these are the bad ones, these are late decelerations. Now what are late decelerations? Can you see how this fetal heart is dipping? Okay, and how the uterine and how it's dipping in relation to uterine contraction? Can you see the trough or the nadir of this deceleration is happening after the peak of the contraction? It's a nice symmetrical slow drop, but very important, the nadir or the point of bottommost point of the deceleration is occurring after the peak of contraction. See again here how it's happening after the peak of contraction, how it's happening after the peak of contraction. These are a very dangerous thing to see. This means there is fetal, I should write it with red, I think. Okay, this is fetal distress or a hypoxic fetus, and if you see these, you should not waste time and you should plan immediate termination or delivery of this fetus if you are seeing these types of deceleration. Okay, so these are late decelerations. Late are not good. Okay, late means you're late, you've missed the bus. Okay, so late decelerations are not good. Whether you miss the bus, that means fetal distress is happening and you need to take urgent action. The third type of deceleration is variable deceleration. Now, variable deceleration have no relation to uterine contraction. Some of them may happen. You can see this is happening somewhere in the middle, this one also. So there is no relation to the uterine contraction. It's called as variable. And variable are seen typically when the cord is getting compressed. Okay, so in cord compression, where will you see cord compression? When there is less cushioning of the cord, that means there is less amniotic fluid or there is oligohydramnios. So remember, variable decelerations happen because of cord compression. Late deceleration happen because of fetal distress. You missed the bus. It's late now. And early deceleration happen because of head compression, which is seen classically in the second stage of labor when the head is descending the maximum. So the next type of deceleration is something called a prolonged deceleration. What you're seeing here is a prolonged deceleration. What is a prolonged deceleration? It is a drop in the fetal heart rate by 15 beats per minute or more, but it is lasting for, can you see how long this is lasting for? If it is lasting for more than 2 minutes, it is called a prolonged deceleration. So anything between more than 2 minutes but less than 10 minutes is called a prolonged deceleration. If it's lasting more than 10 minutes, it becomes fetal bradycardia. Okay. Where is it seen? Very important. Two classical conditions where this is seen is in cord prolapse. Prolapse of the umbilical cord. So these are acute emergencies, and abruption. Intrapartum abruption, if it happens, you will find prolonged decelerations lasting more than 2 minutes. Again, a sign of acute fetal hypoxia. Again, a sign that you need to take action immediately and take this baby out. Cord prolapse, abruption, seen in prolonged deceleration lasting more than 2 minutes, less than 10 minutes. If it's lasting more than 10 minutes, the definition changes to fetal bradycardia. Okay, and a very important, the last one, it's not a deceleration, but it's just a type of CTG, and you can see this is this pattern. This is called a sinusoidal pattern. Sinusoidal pattern of the fetal heart rate, and this is a sign of fetal distress. It is not a good thing to see. It is a sign that the fetus is distressed, classically seen in fetal anemia. Okay, so where will you see fetal anemia? Remember two conditions. One is vasa previa. We'll discuss this again in antepartum hemorrhage. Vasa previa is when there's sudden loss of fetal blood. Okay, and the second condition is in an RH isoimmunized baby with fetal anemia. So if the baby is RH isoimmunized and has fetal anemia and goes into labor, you may encounter this pattern. This is called a sinusoidal waveform, and it is not a good sign. It is a sign of fetal distress. So late decelerations, prolonged decelerations, sinusoidal pattern are signs of fetal distress. Early decelerations are seen in head compression in the second stage. Variable decelerations are seen because of cord compression. Now, interpretation of the, although this is what you need to know for your exam point of view, this is where your questions come from. Interpretation, say a question has never come, okay, but you need to know a bit about interpretation. So I just put it together in a quick table. What is a reassuring CTG? A reassuring CTG is one where the baseline fetal heart is good, the variability is good, there are no decelerations and accelerations are present. So this is very easy to understand, a reassuring CTG. Then comes a non-reassuring CTG. What is a non-reassuring CTG? So the first is reassuring, second is non-reassuring. Non-reassuring is when there is now mild brady or mild tachy. That is, this is the fetal heart rate 100 to 109 or 161 to 180. The variability is less than 5, but it doesn't last more than 90 minutes. Okay, it could be less than 5 but lasting for less than 90 minutes. Early decelerations, variable decelerations, or a single prolonged deceleration. So early, variable, we know these are not that bad, and a single prolonged deceleration. So the absence of accelerations with an otherwise normal CTG are of uncertain significance. So accelerations, if they're there, very good. If they're not there, it doesn't have much significance in labor. Okay. So this is a non-reassuring CTG. And the third type, okay, is the abnormals. You have reassuring, you have non-reassuring, and this is the bad one. If you have bradycardia, less than 100 fetal heart, or more than 180, or a sinusoidal pattern, or the variability is less than 5 for more than 90 minutes, or if there are atypical variable decelerations or late decelerations, or a single prolonged deceleration lasting for more than 3 minutes, okay, then it is an abnormal CTG and indicates fetal hypoxia, and you need to deliver this baby. Okay, so interpretation could be reassuring, non-reassuring, or an abnormal CTG. Abnormal CTG is where you need to take action. A non-reassuring CTG, you need to increase vigilance. What do we do with a non-reassuring CTG? We hydrate the patient. We check for any abnormal factors, maybe this cephalopelvic disproportion, okay, or we give oxygen to the mother and we make her lie in the left lateral position, and this may help improve the CTG. Okay, but an abnormal CTG is bad and we need to take urgent action and deliver this baby. So another type of intrapartum fetal monitoring you all should know is something called fetal scalp pH, blood pH, and lactate level. So if the CTG is abnormal, what can be also be done to actually see if the baby is hypoxic or not is something called measuring the fetal scalp pH or lactate levels. And this is done if the cervix is dilated to more than 3 centimeters and the membranes are absent, then only it can be done. How is it done? We put in a special instrument, a tiny needle, which will take a bit of scalp blood, and we send this for pH and lactate level monitoring. What you need to know is that the normal pH, fetal pH, should be more than 7.25. If it is less than 7.2, this is a hypoxic fetus. So remember, less than 7.2, if the pH is less than 7.2, it is a hypoxic fetus, or if the lactate levels are more than or equal to 4.9 millimoles per liter, this is also a sign of a hypoxic fetus. The pH is very important to remember. You should know this value. A value of less than 7.2, less than or equal to 7.2 is indicative of a hypoxic fetus. Also know that in our country, in India, we don't usually do a fetal scalp blood pH and lactate levels. is very commonly done in the UK. So all your RCOG guidelines will mention this. Now, quick revision, and this is very, very important. This is an early deceleration where the trough or the nadir of the fetal heart rate is corresponding to the peak of the uterine contraction. This is a late deceleration. It is not a good one. This is seen in fetal distress where the nadir is happening after the contraction has, the peak of the contraction has happened. Then is the fetal heart dropping. This is a sign of fetal distress. Early decelerations are seen in head compression, and this happens in the second stage of labor. Okay. Variable decelerations happen irrespective of the uterine contraction and are a sign of cord compression, which can be seen in oligohydramnios. Now let's just do some MCQs which have been asked in the past. What does this CTG show? Okay, this CTG is showing, let's see. Okay, so you can see this deceleration is occurring almost with the peak of contraction. This is happening after, this is happening in between. So these are not really related to the contraction, they are independent of the contraction. So this is a variable deceleration. Okay, which amongst the following is wrong regarding late decelerations? They are smooth and gradual. Yes, they are smooth and gradual. They start after the uterine contraction starts and end after the uterine contraction ends. Yes, true. The fall in heart rate is more than 10 to 20 beats above the baseline. So remember, the deceleration is, there's a fall below the baseline. That's why it's called a deceleration. So this is a wrong statement. It is not followed by an acceleration. Yes, a deceleration is not usually followed by an acceleration. This is the wrong statement. Identify the correct feature in this image. So what kind of deceleration is there? Let's have a closer look. You can see this is the deceleration, this is the contraction. Okay, it's happening after the peak of the contraction passes off. Here also, here also. So this looks like a late deceleration. Okay, so this is a late deceleration. Okay, it doesn't look like an early or a variable, but it is a late deceleration. There is also poor beat to beat variability. So this might have been a multiple choice question, and if you have multiple answers, poor beat to beat variability is also seen in this image. Next question. A 23-year-old primate is in labor. The intern on duty informs that the patient is fully dilated and there are decelerations on the CTG. Which decelerations are common in the second stage of labor? Remember, second stage of labor, you see early decelerations because of head compression. Okay, so the correct answer is early decelerations. Okay, so remember, hard work itself won't make you productive. You have to include a little bit of sleep, a little time to yourself, healthy eating and exercise. Thank you very much.